probably one of the most controversial routes of administration, not in terms of whether we should take them or not, but how to monitor them, is transdermal. So when I'm putting a hormone in a cream or a gel on my skin, what happens to the lab testing is really confusing and a little bit controversial. So we're going to work our way through this, and this is a story that doesn't have a final chapter. We're still really learning as an industry the best way to take transdermal hormones, as well as the most effective, if any, way to monitor them. So what's the big issue here? The issue is you get completely conflicting messages depending on which lab test you're using. So if a woman puts on topical, let's say progesterone, her salivary values are going to go through the roof. They go very, very high. The serum values and the urine values are going to lag significantly behind that, and sometimes they don't go up much at all. Now, this conflicting story is most extreme for the more fat-soluble hormones, meaning progesterone. There's a huge dichotomy in terms of the salivary values going way, way up and the urine and the serum values not quite so much. When you get to the more polar compounds like estradiol, the saliva doesn't go up quite as much and the urine and the serum tend to go up a little bit more. When you move to estriol, even more so. So you end up with these interesting conflict, though, between the two types of tests, either the serum and the urine, which tend to tell about the same story, or the salivary testing. Now, mixed in with this, we also have different conflicting philosophies for people taking hormones. So some people want to get postmenopausal women in a postmenopausal range. Some providers want to get women up into a premenopausal range, even if they're postmenopausal, and sometimes somewhere in between, but we have these different goals. But even when we just focus on one and say, okay, here's our approach. We want to get women who are postmenopausal, if this is your approach, into a premenopausal sort of range. We say, okay, that's our approach. Well, you're going to have a completely different dose that you're going to use, whether you're following the saliva results or whether you're following serum or urine results. So it's very common for estrogen doses to be at 0.025, 0.05, or all the way up to maybe 5 milligrams. That's 100 times difference. With progesterone, same sort of thing. You can have progesterone doses of 5 milligrams or 500 milligrams, right? That's obviously a difference of 100-fold. But the point is you can get to these doses using the same philosophical approach, but a different lab test. If I give a woman 5 milligrams of topical progesterone, a lot of them, their progesterone in saliva will go from a postmenopausal value of, say, 25 or 50 up into the premenopausal range of 100, 200, right? If we then switch and say, this is my approach, I want to take a woman from a postmenopausal level to a premenopausal level, but I'm going to use serum testing. Now that 5 milligrams will do absolutely nothing, and you can get upwards of 500-600 milligrams before you're driving that serum up from less than 1 for a postmenopausal woman up into 5, 10, 15 nanograms per milliliter where premenopausal women reside. And remember, we need to be critical in our evaluation, and we need to evaluate each test independently. Does salivary testing work to monitor topical hormones? That's a question that should be asked. If the answer is no, it doesn't necessarily mean that urine or serum testing do work. So let's look independently at saliva testing. Here are the reasons why, for me, I do not believe it to be effective for monitoring topical or transdermal hormone application. So one, the values are highly irreproducible. That doesn't mean the lab value, meaning if I take the same saliva sample, I can get the same number. But if I collect day after day after day, and I don't change anything in the therapy of the patient, the value is simply not consistent. So we've done that in-house at Precision Analytical. We've taken a woman and put her on transdermal progesterone, 50 milligrams, day after day after day, 12 days in a row. And we had saliva and we had urine collections. And when we look at those values, the values in saliva, again, these are meant to be the same every day. That's 12 hours after supplementation, same dose, same application site, etc. And the values range from in the 100s all the way up into the 6,000s, right? And everywhere in between. So you get over 12 days, 12 values that are greatly spread out. And if you look at data taken from many, many patients taking, again, 50 milligrams of transdermal progesterone, you get about the same spread of data from a couple hundred all the way up to 6,000. So the assumption you're making going into this is if I test a patient and she's on the higher end, let's say she's at 5,000, that if I test her again and again and again, she's going to be reproducibly at this higher level, which gives me the message of, okay, maybe I'm overdosing this patient. Let's scale back her dose a little bit. And now I get a value of maybe 800, 900, 1,000 in this same range day after day. But that's just not reality. When you look at this one patient, she spanned the whole spread of data that a whole group of people would span taking the same dose. Now, if we look at this study that was done with University of Southern California, Dr. Frank Stanzik, what they did is they took a group of women and they all had progesterone put on their thigh day after day after day. Now, after a couple of weeks of this, they then tested. One of the measurements was done, the first measurement, as you can see here, and we're showing the data from not just the salivary value, but also the blood spot values, which also tend to increase with transdermal hormones a whole lot more than serum or urine testing. But here's what we found, is that we tested them, they had hormone reapplied, and they tested again 24 hours later. Both of those numbers were 24 hours after the last dose. So we should get reasonable precision. And as you look through the data, what you find is the most common scenario is from one day to the next for those values to differ by about a factor of 5. That's not useful in terms of monitoring dosing. If all we have to do is wait for the next day and test again, and we get a value that's so very different, that's not going to be useful in terms of monitoring therapy. Now, keep in mind, that is standardized in terms of where the hormone's going, right? In those situations, the hormone is going all in the same location. Not only are salivary values highly irreproducible when you don't change anything, right? I'm treating a woman the same day after day, and I'm collecting day after day at the same time point relative to the supplementation. Not only is that problematic, but when you start moving that hormone closer to the saliva gland, the values change surprisingly quite a lot. So look at this data. From one individual, the hormone was placed near the saliva gland and then further away sequentially on different days, right? So the peak values, now these are not values 12 hours after, 24 hours after. These are the peak values just so we can see this relationship. But look at the magnitude of the scale. The numbers are changing dramatically as you're moving that hormone away from the saliva gland. So that's going to create a huge issue in terms of standardization. But even if we're able to standardize and say, okay, let's all put our hormone in the same place, this data also tells you something about the manner in which the hormone is actually getting into the saliva gland, that it must be some sort of diffusion of sorts in that possibly through subcutaneous fat or some of the shallow lymphatic system that this hormone is getting shuttled to the saliva gland, and it may be getting to the saliva gland in concentrations that are much different than it's getting potentially to other tissue. When we think about that hormone getting into the saliva and being in much higher concentrations the closer you put it, there are some things that we need to think through in that in terms of using facial creams that have hormones and things like that. But it also teaches us something about how the hormones get in there. The other bit of information that really adds to this picture in a way that's disconcerting in terms of using salivary testing to represent other tissue is that salivary values don't decrease when you stop supplementation for sometimes weeks. So you can see from this study here, it was more than 12 weeks after the cessation of topical progesterone before those salivary values came down anywhere close to the baseline values. And we've got a lot of data from women who were formerly taking progesterone where we see very, very elevated salivary values as long as 7 months after the supplementation stopped. So if we have a very simple approach of saying, look, the amount of hormone in the saliva represents the uterus, represents the breast tissue, would we then assume that 6 and 7 months after supplementation with reasonable doses that you would still get, for example, endometrial protection from taking estrogen simply because we have an elevated salivary value? probably that's not a safe assumption, especially knowing that urine values and serum values are going to return to baseline relatively quickly after we stop the supplementation. So another point we want to look at is, what evidence do we have of tissue uptake of hormone? Well, with testosterone, we've got a marker that we can follow that represents the brain. And what we see is that when you put a man on too much testosterone, what happens? LH is the hormone in your brain that is responsible for telling the testes to make testosterone. So if you give a man gobs of testosterone day after day after day, the LH will go all the way to 0 and the testicles will stop making testosterone. So what we see with 50 milligrams of topical testosterone from the research is we see that hypogonadal man, that means these men are testosterone deficient and their LH value starts elevated. When you give them 50 milligrams, that's the middle line here, that's the middle dose, the LH goes from elevated to normal. That is a modest decrease in the response to the brain of the testosterone, right? What happens in serum and urine? You get an analogous modest increase in testosterone. Those two things make sense. When you look at the salivary values, you get at least a 1,500% increase. That data is taken from 12 hours after supplementation. 1,500% increase. If there was a legitimate tissue increase, at least in the brain, of 1,500% of testosterone, we would expect the body's response to that to shut down the production of LH, and that's not what we see, meaning the message that the brain receives with transdermal hormones is not the message that the saliva gland gets. Okay, so when you add all these things up, the variable numbers, the difference based on location of application, the fact that the hormone can stay elevated uniquely in saliva for so very long, and the fact that our signaling hormones from the brain are not moving as the saliva levels move, it's probably not an effective way to monitor therapy. While this combination of data may help us to conclude that salivary testing is not going to be effective in terms of monitoring transdermal hormone therapy, it doesn't necessarily mean by default that urine testing and serum testing work. When you look at these intellectual objections to transdermal hormones monitored by saliva, on each one of these points, urine and serum testing do much better than saliva testing, but they have their own list of questions that we need to work through. For example, the saliva gland is a tissue. That tissue is not well represented by serum or urine testing. That much we can say very convincingly from all of the salivary data. So then, does a level in urine or serum well represent the uterus, the breast, muscle tissue, these other tissue? And that, I think, remains to be explored a little bit. We need to be careful so as not to overdose our patients, not realizing that some tissue have a higher hormone burden than is reflected in urine and serum. Now, another issue that we need to look at is just how much progesterone does it take to balance estrogen? This is actually a pretty tricky question because when I take progesterone and estrogen, the levels in saliva go up a lot more than the estrogen, the progesterone levels do. So you're getting this massive picture of abundance of progesterone, and there's no way you could conclude that estrogen is dominant in that particular situation. However, in those same doses at that same time, when you look in urine, the progesterone lifts the urine value a lot less than the estrogen. So when we come to questions of what target values we should use in terms of balancing out the estrogen and progesterone, we know that we get conflicting messages in saliva and in urine or serum testing, but when those doses are perfectly well balanced is a little bit still of a mystery and something that needs further exploration. One of the topics within this conversation that deserves a lot of attention and further exploration is the method in which we actually apply transdermal hormones. We find that, for example, we see more of a serum increase oftentimes with an alcoholic gel than with a cream. A transdermal patch is a good example. If you put a transdermal patch on, you're in a completely different place than if you're using creams and gels, in that it drives up predictably urine and serum values in more of a dose-dependent manner. I've worked with individuals who are doing things a little more creatively of putting the hormone in an alcoholic suspension. If you stopped right there, you'd probably find that a lot of the hormone would just stay on the skin as the alcohol, the ethanol, evaporated. What they're doing is then coming behind this application with something like almond oil and rubbing it vigorously over that same location and finding that the serum values and the urine values are driven up much, much higher with this type of application than with your more traditional cream or gel application. Also, the location of administration, many people finding that using thin-skinned areas seems to work a little bit better when using these alternative routes of administration within the family of transdermal hormones. It's more effective at getting serum values up, and so there is more of an effort that needs to be done to standardize the manner in which we actually give transdermal hormones in the hopes of finding some scenario where we can have reproducible, linear, dose-dependent responses so that we can more effectively monitor the hormones, although that will always come with the caveat of knowing that in any of those situations, you're going to have a saliva gland that's full of a lot more hormone than what you're seeing in urine and serum, and that needs to be taken into consideration because there may also be other tissue where the amount of hormone is actually elevated above what you see in the urine and serum. And so we want to be cautious and lean heavily on the clinical picture and what research tells us about what doses may actually be most appropriate.